Okay, she is going to need Rogaine. Okay. All right. So here's another next gen style question. The nurse reports these findings to the provider. The client's vaginal fluid, she came in complaining about leaking. We need to assess if it is amniotic fluid or if it's urine. Okay. So we test it. What do we use? What kind of a test do we use to test the pH?
Strips.
Acid
What kind of
test,
strips?
I
pH.
don't remember. pH strips.
Yeah, pH strips. They're called nitrazine strips. I think that's how you spell it. Nitrazine strips. Okay. So if it turns green, blue, more blue-green color, is that alkaline or acidic?
Alkaline.
Alkaline. So if our strip is alkaline, it means the fluid is alkaline. So do you know if that's amniotic fluid or urine?
Probably amniotic.
It's amniotic.
Yeah.
Urine
So
is acidic.
amniotic, yeah. Urine is acidic. So it's going to be more yellow orange. Okay. But if we take our strip and test it in the fluid and it's blue, then we know it's amniotic fluid. Okay. So we can verify that she's been leaking amniotic fluid. We can also take some of that fluid and put it under a microscope. And what you'll see is what? Option 2. You know what? So you're going to see what's called a ferning. Okay. It's just the liquid will look like it'll have a shape of a fern, which is what's up here in this picture. This fern here. It kind of looks like we call it ferning. So once again, we can verify it's amniotic fluid. And then the client is admitted and scheduled for what? Do you know what we would schedule her for? She's not in labor, but she's been leaking fluid all day. So she needs to have her baby delivered.
Ultrasound.
Labor induction.
A labor induction. Yeah, a labor induction. Yeah, we need to get her started in labor. Her fluid's been leaking all day. And so her baby's susceptible to get an infection. So we need to go ahead and induce labor. Okay. So the provider notes that the client has a history of group beta strep and orders penicillin. We need to verify that our client is not allergic to it. Okay. The nurse points out to the provider that the client is also Rh negative, so she will need some Rogaine. Right after a baby's born, we do collect cord blood, okay, and test it for a lot of things. But one of the tests is what kind of blood the baby has. Okay. If the baby's a negative, like mom is, then we don't have to give her Rogaine. But if the baby has an Rh antigen attached to her red blood cells, then we do need to give her Rogaine. Okay. All right. So do you know what medication we use to induce labor?
Those.
Oxytocin. So 4 hours after induction began, the client's having regular contractions every 4 to 5 minutes, and they're lasting 60 seconds. The nurse is reassured by the fetal heart pattern. What does she observe? So there's 3 different patterns I've got on the screen here. Which one would you expect that she observes since she is reassured? And if you don't know, A is correct.
It's A. Okay.
Early decelerations are okay. Fetal heart rate is good. Moderate variability is good. Okay, the other 2 are not good. Any late or prolonged deceleration means that the placenta is not getting oxygenated blood. Okay, and we're going to talk about these things today. So you'll get a little clearing of the mind later. Okay, so labor continues, and the client's now 4 centimeters, 70%, and the baby is at 0 station. Contractions are becoming uncomfortable for her. Remember, she wanted to do a natural birth and didn't want any medications. But the client is doing well with a doula. Anybody familiar with what a doula is? Yes, Lene? Do you know what a doula is?
Um, it's someone that is not a doctor that helps you give birth.
Okay, very good. Simply put, but very accurate. Yeah, she's not a clinician, but she's like a labor coach. And she has been working with the client, helping her with breathing exercise and some non-pharmacological things. She can't prescribe medication or anything like that. She's not a clinician. Okay. So we need to do some teaching. Okay. So tell me which ones are indicated. Which of these teachings are indicated or contraindicated, or maybe they're just not essential for the moment. Keep in mind, she's in labor and she's beginning to hurt. So what's essential? What's indicated? Okay. The first one, upright positions, including walking, can sometimes help during labor. It increases circulation and comfort. Is that indicated?
Yes.
Yeah,
Yeah,
indicated.
yeah, sure is. It looks like you're in a lot of pain. So she's validating the client's pain. I'm going to call anesthesia, is what she says. Is that indicated?
Contra.
Contraindicated. She says she want a natural.
Wants natural birth.
That's right. It's contraindicated. What about your baby's heart rate is not reassuring? Okay, so I need to call the provider.
Indicated.
Be indicated if his heart rate's not good.
Not. I think it's indicated. Yeah.
Okay, well, indicated, contraindicated, maybe it's the wording. I don't think I would use non-reassuring with a client. I would probably say the baby's heart rate's a little lower than what I really like to see it. I'm going to contact the provider. And in the meantime, you know, as a nurse, what are some other interventions you can do? And the first thing you would want to do is roll her up on her left side. When we roll our clients on the left side, the placenta gets better perfusion. Okay. So that's what we would do. Usually if the placenta is not getting good perfusion, the baby's heart rate is going to drop, and we call those decelerations. Okay. So we can say it's indicated in some ways. Okay. Your labor will be longer because of your age. So she's 40 years old. Yeah. Would you say that to someone?
No,
No.
not
Oh.
essential.
Essential.
Non-essential.
No matter if it's true or not, I wouldn't say it. No, that's contraindicated.
Oh, contraindicated.
And then the last one, you may have some clear fluids to stay hydrated.
Indicated. Or it
She's
doesn't matter.
hurting. Yeah, it
Yeah.
really doesn't matter.
It's
It's
non-essential.
non-essential. We would have told her that early in the pregnancy. So that's kind of non-essential, okay? Because right now we're addressing her pain, okay? Okay. One thing we do when we induce labor, when we start labor with medications, is that we have to assess whether the cervix is soft, whether it's beginning to dilate and thin out, and what position it is. So we use what's called a Bishop tool. Okay. So here I have a picture of, over here on the right with this baby. So at the top, it shows the effacement occurring, the thinning of the cervix. And then the second group down is the dilation of the cervix. Those are two measurements that tell us that labor can be started if these are far enough advanced. So with a Bishop score of like 7 or 8, we can pretty much go ahead and start contractions. But if her Bishop score is low, In other words, if her cervix not soft or it's not dilated or not effaced, there's nothing going on with the cervix, then we have to use a medication to help accomplish that. And you're not going to be responsible for the medication for this exam, but later on when we talk about higher risk, we'll go into this in more detail. So as far as Bishop score, it's just the inducibility of labor, okay? The successful inducibility. Okay. So at this point, she's progressing. We've been doing non-pharmacological management, walking around, massages, warm showers, using the ball, all kinds of things we can do to help her manage her pain without medication. But now she's angry. She's getting really frustrated and she lashes out at you. And she said, it hurts so much. I can't do this. Get somebody in here who knows what to do. So that's kind of offensive to a nurse. So how should you respond? How
Is
would
this
you
the lady
respond?
that's still, what was she, 10 centimeters?
Yeah, she's probably not 10 centimeters, but she's starting to have a lot more pain. How do we respond to her pain? It's not, I'm not asking you for the blocks down below. I'm just asking you, how do you respond verbally to
Oh,
her?
okay.
Ask her
I'm
if she
sorry, I
wants
didn't.
something for the pain.
I'm sorry.
Did you ask her if she wants something for the
Mhm.
pain?
Okay. That's very appropriate. Even though she said she didn't want to, you could tell her, would you like some medication? Because keep in mind, or of course you don't have the experience, but I know there have been a lot of women that wanted to do it naturally. They couldn't. It was just too difficult for them. So we ended up, if it's not too late, we put an epidural in, okay? So yes, we do need to offer. That's one thing you could say. Yeah. Or you could say, do you want me to find the anesthetist to come talk to you about an epidural? Things like that. Okay. Or just talk to you about pain medications. Okay. So what are her options? Well, we can do opioids. Okay. If we wait too long and she's dilated to 8 or to 10 centimeters, and then she's asking for pain medication, because sometimes a transition, stage 2, lasts a couple hours, okay, when the baby's being delivered. So, but if we wait too late, an epidural is not really going to help, and you'll learn why. Opioids are dangerous to give late in delivery because it affects not only the mother, the central nervous system depressant, the mother, but also the fetus. So your fetus is not going to be alert, going to be a little lethargic when it's born. So it's not going to have the respiratory effort that we really want it to have. Okay? Epidurals are ideal. Pudendal blocks, will find that they are good for that late stage when it's too late for an epidural. Okay. So we're going to talk about that today. And then we were able to deliver with a pudendal. We did a pudendal on her and she delivered a new baby girl. Okay, so that's a start. Let's see. I've got somebody in the chat here. Oh, okay, Lisa. You can just speak out. You don't have to write in the chat. Okay. What do we want to do next? Okay. I do want to show picture real quick. This is a document I gave you. You can see that the document is talking about induction of labor, okay, and the medications we use and all that. But this is a picture here of before labor when not much is going on with the cervix right here. And then as contractions occur, the cervix actually gets shorter and thinner. We call that effacing. And then it dilates and it actually opens up. So to the point where you can't even palpate it. Okay. So if I would do my vaginal exam, I wouldn't be able to find the cervix because she's completely dilated. She's getting ready to deliver the baby. Okay. All right. Any questions so far? Of course, I hit you with a lot of stuff. Okay, let's play. It's kind of like a game. So what I have here is the slide I'm going to work on. You see, there's a bunch of boxes here on the side. This is like a matching game. So this is review from last week. Most of it is. So when we see a non-stress test, we talked about, I think we talked about that last week. It's part of the content from the second week. So a non-stress test, does anybody remember what it is? Why we do it? Anybody remember? So you see a list of statements over here on the left, the lettered statements. Which one describes a non-stress test or what a non-stress test is doing? Anybody know? Do we want to move on? How about cardiac output increases in pregnancy?
I mean, the stress test is judging your cardiac output. So would that be the non-stress test?
No, it's not the
Or no?
non-stress test.
Okay.
So which one can I match with cardiac output increasing during pregnancy? Which one of these boxes over here?
Is it oxygen demand for placenta perfusion?
Exactly. Where is that? Here it is. Oxygen demand for placental perfusion. That's exactly right. Okay. Plasma volume increases more than RBC volume during pregnancy.
Is that the physiological
Physiological.
anemia?
Anemia.
Yeah. What about maternal hypotension and fetal decelerations?
Is that where the non-stress one would go?
Left
Nope.
lateral position? I know that's.
Yeah.
Yeah,
You definitely want to use the left lateral positioning. You're right. But there's another one over here too.
uterine placental
Hypotension.
insufficiency.
Yeah, the insufficiency. So in other words, once again, if we know that mother blood pressure drops, we expect the fetal heart rate to drop. Okay, there's not enough uteral placental blood flow is insufficient. And the first thing we do when we notice decelerations like that, even if it's related to low blood volume, is we turn mom up on her left side. So both of those are good. Oops. For that. Okay. All right. What about knee chest positioning? Just another position.
Supine hypotension.
Well, it would be the uterine placenta would be the same as this one. I need to really take that out. Action for decelerations would be left lateral.
Left lateral.
Yeah. Okay. What about facilitate or inhibit progress of labor?
5 Ps.
The 5 Ps. Yes. The factors that can enhance or cause problems during labor. Adequate fetal oxygenation.
Is that the non-stress test?
Yeah, here's the non-stress test. Yeah. So we do the non-stress test. We want to watch the fetal heart rate go up when the baby moves. So the mom lets us know when her baby moves. She pushes the button and we want that movement, to last, heart rate to last accelerated 15 beats more for 15 seconds. Okay. What about intrauterine growth restriction?
Supine
Fine
hypertension.
hypotension.
I don't even know what I wanted to put for that. It's not supine hypertension, it has to do with blood flow. So intrauterine growth restriction is that the quality or the lack of oxygenated blood. In other words, a really good example of something that inhibits the growth of the fetus, intrauterine, is nicotine, smoking. That causes blood vessels to clamp down, or antihypertensive medications, okay, cause the intrauterine growth restriction, IUGR, we call it. Okay, so what is -3 + 7 + 1?
Nigel.
Yeah, Jules.
Yeah, Nagel's rule. What builds the endometrium, relaxes the uterus, and may cause low back pain?
Progesterone?
Yep. What's the term autorecessive referred to?
A sickle cell. Partner
Partners carry the same gene.
Yes.
Pills.
Cervical dilation and effacement.
Supine hypotension.
No,
Nope.
fine hypertension is M.
Oh,
Adequate flow.
and Chadwick is probable.
Yeah.
Mm-hmm.
Yep. Okay, good job. So there's a lot of information there. Okay.
Can you put that back up? You took it down so quickly.
Probably.
Do you want to take a picture?
Yes, ma'am.
Let me move this around. Let me move this up here. Although it goes in a lot of places.
Professor, what was L?
L is there's nothing to match L. It was an excess.
Okay.
Thank you.
You're welcome. All right. So we're going to go through, I don't want to go too quickly. There are 24 slides here. So we're just going to go over a few and then we're going to take a break, okay? So let's talk about our assessments during the intrapartum. What is labor? What is labor? Labor is regular uterine contractions that are changing the cervix. So two things, those both facts have to be occurring, okay? So I'll add it here. So labor is regular uterine contractions that change the cervix. In other words, that dilate the cervix and efface the cervix. So you need to be familiar with dilation and effacement. So in this picture on the right, you'll notice at the top, the babies, right? The babies engaged in the vaginal canal. I mean, not in the vaginal canal, in the uterus. And the cervix is closed here. You can see that thick cervix. So nothing's occurring. If she's having contractions, they're not doing anything to help open that up. The next picture shows that she is completely effaced. And I have some other pictures to show you. In other words, that cervix is completely thinned out so much that you don't really see it anymore. Okay. So 1 centimeter dilated, and the next one shows that she's dilated now and it thinned out. So this is what we call effacement and dilation. The last one shows that her cervix is completely effaced and completely dilated at 10 centimeters. So that when I do my vaginal exam with my 2 fingers, I'm not going to feel any cervix. So it's completely shrunk up. Okay. The next one shows how contractions actually occur. They start usually toward the top side, the strength of the fundus. Okay, so the fundus is the strong muscle, and that's where the contraction begins. And then it spreads throughout the uterus. Okay, so what it's doing, it's spreading, and as it spreads, it's contracting, and it's causing that lower uterine segment to be pulled up, which effaces and dilates the cervix. Okay. So labor is the onset of regular uterine contractions that change the cervix. So if she says she's having contractions, they're irregular, and her cervix isn't dilated, then she's not in labor. Okay. So that's how we define it. Okay. And we don't know how it starts. We suspect that there's some prostaglandins that the fetus might release in the system that causes contractions. Or it's this, the progesterone drops and she goes into labor. Okay, so this is our nitrazine strip. Okay, so you can see at the top, that would be the urine. It's more acidic. And at the bottom, that would be your amniotic fluid. So it's more blue. So some things that the client might experience just before she goes into labor. So there's symptoms. Okay, lightning. Lightning drops out of the sky, right? Well, lightning also is a baby dropping from the sternum into the pelvis farther. So baby drops in mother's belly. That's what we call lightning. Braxton Hicks are contractions, but they're not like labor contractions. They're more of a tightening of the belly. So she might have some tightening that occurs. She might notice increased vaginal mucus. Some of that mucus plug might be being released. The operculum, it's called. Okay, her cervix might begin to soften before she's in labor, and it might even dilate and efface a little bit before she's actually in labor. And her water might break, right? She might have a surge of energy. It's like a nesting. She wants to do last minute things for the baby's arrival. And then bloody show means that she might have a bloody vaginal discharge. So those are preceding symptoms of labor. So here are the 5 P's that was in that other slide I said I showed you with our client. The 5 P's of labor. So the 5 P's are factors that affect the progress of labor. Okay. So if you had a client that had a narrow pelvis, the passageway was narrow. The structure was too narrow, and it was hard for the fetus to navigate the passageway. That'll hinder labor progress. Okay. If she's had a lot of scar tissues, that's part of the passageway too. Okay. The passenger is the fetus. So we need to know, if the lie of the fetus is such that it's more difficult to have labor, if the baby is transverse or breech. So the lie of the baby, what's being presented is it the head Is it the face? Is it the feet or the butt? Okay, so all those different presentations in the lie of the baby, it will hinder or facilitate labor. And then the fetal attitude. That means, is a baby in a flexed position? A flexed position is most ideal for labor. And then if the baby is large, that's going to hinder labor. A large baby from a diabetic mother. So that's the passenger in the passageway. The next P are the powers.
With that, when you say big baby, would it also pertain to like the length of the baby?
Yeah, it could be the length of the baby. If the baby is long and is not flexed, it's going to change the presentation. Yeah. But usually it's the size. Okay. So a macrosomic baby is diagnosed at 4,000 grams. And that's usually the diabetics. Okay. Powers of labor. There's two powers that allow labor to begin and to progress. So we've got contractions. We've talked about contractions. Contractions are the primary power for the baby to navigate through the canal. The secondary power is mother. She has to push. Okay, so that bearing down that she does during the stage 2, when she's fully dilated and fully effaced, she can begin pushing during contractions. Okay, and then the position of the mother. Okay, usually squatting, standing, just an upright position is going to be more beneficial because gravity is going to help with delivering that baby. And it's just recommended that we do a lot of position changes. You know, it does help if I get a woman out of bed, if she can tolerate standing at the bedside and leaning over onto the bed, okay, or squatting at the side of the bed, or sitting on a ball, that improves circulation to the baby and to her. It helps to relieve fatigue. Sometimes it's just more comfortable to change positions, and then we know it improves the circulation. Okay. And then the last P, so we've got passenger, passageway, powers, position, and psychologic response. In other words, the mother's mental and emotional state. If she didn't attend any childbirth classes, she might be a little anxious, especially if this is the first one. So our client, our 40-year-old client, might be a little anxious, especially since she, you know, had to have in vitro fertilization. Now she's got a little anxiety about that labor. Okay. She wanted to go medication free, but she couldn't. So she might feel some sense of disappointment. Okay. So she might have some anxiety. And if we have a client that's cannot relax between contractions, she's going to wear herself out. And not only that, it reduces the effectiveness of uterine contractions. Okay. And it diverts blood. If you're nervous or scared, you have catecholamines circulating, you know, epinephrine and norepinephrine, they're circulating in your body. Like if you were, your heart rate goes up, and that reduces blood flow everywhere else except the heart and the brain. So we don't want her to be anxious. Okay. And then of course the cultural aspects. Okay. Make sure you're addressing those during her labor. So what you need to know about these 5 keys is that they hinder or they can help labor. Okay, these 5 P's. So you need to know the 5 P's, what they are: psychologic, position, power, passageway, and passenger. Now the passenger, there's several things under the passenger. It could be the size of the baby, the lie of the baby, but position also refers to mother. So passenger, passageway, powers, position, and psychologic response. Okay. So remember, or not remember, but precipitous labor is a labor that begins and ends within 3 hours. That's too fast. That's too fast. It can cause injury to the fetus or the mother. Okay, so this is a high risk situation, and she might even bleed too much after labor. So she's at risk for a postpartum hemorrhage. Okay, so just this is what the different things about the fetus, the different lie, the different positions in the attitudes. Okay, so let's start with the attitude. The attitude just refers to, is the fetus flexed, the head bending forward, and the arms and the legs flexed. This is the best position, the best attitude for a fetus to transgress through that birth canal, the flexed position. Okay. And then the fetal lie is kind of self-explanatory. Where's the head? Where's the butt? You know, we do our Leopold maneuvers and we can determine pretty well the lie of the baby. We know. We might not know for sure if the baby's flexed or not. Okay. The station is just, where is the baby in relation to the pelvic inlet or the pelvic structure? Is the baby engaged? When the head reaches 0, it's considered being engaged. Okay, so that's right there at the ischial spines. That's station 0. So -1, -2, -3 means that the baby is not engaged yet. And then +1, +2, they're on the way out. So that's a station. And we can usually do that when we do our exam. And then the position. Now this is about, where is the baby in relation to the mother's spine? So some of you might have heard the term back labor. In other words, a lot of labor pain is felt in the back. This can be attributed to baby's position. Okay, so position, we're talking about cephalic lie, in other words, head down. Okay, so the back of the head is the point of reference. So on the left here, the right occiput anterior, or ROA, means that the right side of the mother, the occiput of the baby's head, which is the back of the head, is facing anteriorly. Okay, so the back is on the right anterior of mother. So it's facing forward. And then the other one is the left occiput anterior, LOA. Okay, this is the most ideal position to begin to be delivered and to descend during that transition and during delivery. It's the most ideal position, either one of these. And then the other one, this is labor pain being in the back. Send that to the back. Okay, so this is the occiput being against the mother's spine, the sacrum. And it's kind of painful because that head is hard. It's pressing against mother's spine, so she's going to have back pain. So the occiput is on the right side or the left side, and it's facing backward. So it's up against the spine. So it's a posterior position. It still is a good choice for labor. It's just not as comfortable. So that's the position of the baby. Okay, we'll answer this question, then we're going to take a break. Okay. So practice question. You did Leopold maneuvers on your client to see what lie the baby is in and what position the baby is in. And you determine that the baby's in the ROP position. Where do you want to put your probe to listen to the heartbeat?
Is it C?
See,
Yeah, so you're going to put it on the right side, below the umbilicus. So the umbilicus is probably about right at the baby's butt. Okay, right at the baby's butt. Or just above. Okay. So let's go ahead and take a break. We'll come back at 4:30 or 30 minutes after the hour and continue. Okay. Okay, so the stages of labor. So stage 1 is labor. Okay, labor before the delivery. Okay, so that's stage 1. So when we know our client is having regular contractions and we're noticing changes in the cervix, we know she's in labor. So stage 1 begins with the onset of regular contraction, and it ends when the cervix is completely dilated and effaced. During that first stage, there's 3 phases. Okay, so while she's in labor, at the very beginning, she might still be at home. It's considered a latent phase, and she's dilating, but she's having contractions 20 minutes apart. You know, it's not an active labor, although it's labor, okay? So she begins to be more active when she reaches about 4 centimeters dilated. So there's an active phase. So this is the majority of stage 1 is the active phase. Okay, she has to go from 4 to 7 centimeters, and usually 1 centimeter in a couple of hours is probably I wouldn't say the best. It'd be better if it's 1 centimeter every hour, but most clients usually dilate 1 to 2 centimeters every hour. Okay. So an active phase, you don't have to know the specific numbers. Okay, just know that there's a latent phase, there's an active phase. And then when she reaches that 8 centimeter mark, she's really hurting now. She didn't get any medications. So at this point, at 8 centimeters, it's too late to do an epidural. Okay, so we have to rely on another source of pain management. Okay. It's called the transition phase. And during the transition, she's transitioning from active labor to the beginning of delivery. Okay, so it's 8 to 10 centimeters approximately. When she reaches full dilation at 10 centimeters and she's completely effaced, that starts stage 2. Okay, so stage 1 is labor. Okay, and there's a transition phase at the end before she transitions into the second stage when she's fully, and during the transition phase into the second stage is a more quiet, there's a relatively calm descent of the fetus. So there's a latent phase in stage 2. Okay. So stage 2 ends when the baby is born. Okay. And sometimes this can take a couple hours to go completely descend and to navigate through the canal. It might take a couple hours. There's no hurry. Okay. So the latent phase is calm. Baby is passively descending. In other words, the baby is descending even between contractions. And then there's more active descent during contractions, between contraction, and she might feel the urge to bear down and push. That's called a Ferguson reflex. I didn't put it in here. I wonder if I can't. I don't think I can. Oh, yeah, I can. It's called the Ferguson. See, I think it's Ferguson reflex. When it's a stretch receptor. In other words, her whole vaginal cavity and the cervix itself and the soft tissue is being stretched. So there's a reflex activity. In other words, she feels like she has to bear down and push. It's just like a bowel movement, if I can put it bluntly. You know, you have to have a bowel movement. There's pressure and you want to push. Okay, so this is the same thing in labor, but it's with the vagina. So there's the active descent. And then the transition, there's another transition phase at the end of stage 2. And this is when the baby's head is pressing against the pelvic floor muscles. So we're talking imminent delivery. Okay. So stage 2, it begins with full dilation and full effacement. We're ready to get this baby out. That's stage 2. Once the baby's delivered, the cord lengthens and then you'll see a gush of blood. And then we're going into stage 3, which is the delivery of the placenta. So for the placenta to be released from the endometrial wall, we have to have more contractions, okay? And mother usually might feel a lot of pressure during this time, but she's more enthralled with her newborn, okay? So she might not even know when the placenta is delivered. So you're going to see that sudden dark gush of blood. That's when the placenta is released from the wall and the lengthening of the umbilical cord. So what do you think is one critical intervention from this point on? You know, the baby's fine. Let's say the baby's fine. What about the mother? What do you think is bleeding? Yeah, bleeding. Excessive blood loss. So we need that uterus to be contracting after delivery to squeeze. Remember, the placenta was attached to the wall of the uterus, and all those blood vessels were like this. So they've separated now. And so the blood vessels remaining in the uterine wall are exposed and bleeding. So we've got to clamp those off with contractions. Okay, so we want contractions to continue. During that 3rd stage, as the baby's being born, we're going to bolus our mother with some oxytocin to make sure we have adequate amount on board to get that uterus to really contract frequently during the 3rd stage. Because we want that placenta to be released and we want those vessels to constrict. So our focus as nurses in the postpartum period is monitoring the fundus, make sure it's still contracting, and watching the blood loss, watching the blood flow, the lochia, okay? So the 4th stage, once that placenta is delivered, now we're in the 4th stage, okay? So the 4th stage is, we want a very actively contracting uterus. We're assessing the fundus every 15 minutes for an hour. We're looking at the lochia. We're trying to express we're going to actually massage the fundus to get rid of the extra clots, okay? So the postpartum nurse has a lot of work to do as well. She's just not helping mom with the baby. She's monitoring mother's vital signs, but more importantly, the fundus. She's doing a complete assessment once she determines that the client is bleeding is controlled, and she's looking at the maternal newborn bonding. So 1st stage is labor with different phases. 2nd stage is the delivery of the baby. So the 2nd stage starts when so the 1st stage is about contractions preparing the cervix, Okay, contractions, opening up the cervix, dilating and thinning it out so that we can go into stage 2 and deliver that baby. So week 1 or week 2, last week, we talked about the physiological changes in the maternal cardiovascular system and respiratory system, among other things. Okay, we know that during the antepartum, she has a lot more red blood cells. She has a lot of plasma. Her heart rate increases. Blood pressure doesn't change much. Her cardiac output is greater because there's more volume and the heart beats faster. Okay, we know that she tends to be a little hyperventilated. She's got a huge tidal volume. Okay, during labor, we're going to see an increase of cardiac output, an increase of blood pressure, especially during contractions. Okay, so there's an increased demand. She's going to have an increased respiratory rate during labor, as you probably already suspected. There's a video here. If I played this, you wouldn't hear it, I don't think. I tried to play it before and students couldn't hear it. Let me know if you can hear it. No? Okay.
No.
But this, I want you, when you get it, as soon as you get a chance, and this will help you understand contractions and changes in the cervix. I want you to watch this little video. It's only 3 minutes, 3.5 minutes. She describes what's going on with the uterus during a contraction and the purpose of a contraction. It's only 3.5 minutes. So take some time, because I think if you open this up and click on it, let's see, I bet I could find it on YouTube, but we don't have time. Okay, I do want you to watch this. I don't know why. It used to work for me, but it didn't. So this is just another depiction of the uterine contractions in action. Okay, so the cervix is long, right? So it's normally over 3 centimeters long. It begins to shorten during contractions to 2 centimeters. I'm sorry, 4 centimeters long and 2 centimeters long. And then it's effacing is what it's doing. Okay. The A, B, and C are what we call effacement. In other words, it's getting thin, it's thinning out. And then D, the cervix is beginning to dilate. Okay. So this is the contractions in action. What does a second stage of labor begin with?
The full dilation and effacement.
Full dilation, yes. A. Full dilation of the cervix and ends with the delivery of the placenta. Oh, no, that's not right.
It's C.
It's C.
Yeah, delivery of the baby.
Full dilation and effacement. Yeah, and ends with the birth of the baby. So stage 2. Caught me off guard. Your book has lots of pictures on non-pharmacological pain management. Just be familiar with some of them. Don't memorize all of them. Okay, some things that we can do.
I
to
think
help.
massage is very important in this one.
Yeah. Massage really is a good distractor. Okay, good distractor. Gait theory. Understanding gait theory is important because a massage, acupuncture, counter pressure are all based on the gait theory. The gait theory, you know, sensory nerves travel from the body to the brain, right? So sensory nerves tell you when you hurt. Okay, they tell you, ouch, it hurts. And the gait theory proposes that if you use counter pressure or acupuncture, you are stimulating larger sensory nerves that block out the pain nerves. Okay, you're using larger nerve fibers nearby, and it blocks the pain signal. That's what the gate theory is about. Okay, so effleurage is usually what the patient does, the client does. Water therapy, you've seen that. TENS units, imagery. I can say I've never seen hypnosis. So pain management in labor is based on what we know about pain causes of pain. So the first stage of labor during contractions, most of the severe pain is around the abdomen and the back. And you can look at this picture. The dark red with stripes is severe pain. Okay, so that's early first stage. Okay, and then the late first stage, it just creeps down a little lower. This is visceral pain. Your viscera are the organs inside your body. That's what viscera. The liver is a visceral organ. The colon is a visceral organ. The kidneys, the stomach, they're all visceral organs. So it's visceral pain during stage 1. Okay. And knowing that, certain medications do better with visceral pain. Opioids aren't going to do a lot with visceral pain. Meperidine works real well with visceral pain, but we don't use it much in labor because it has long-lasting metabolites that the fetus collects. Okay, so we don't want to really use it. It's being used, but we don't like to use it. Okay, so as we go into stage 2, beginning during the transition phase, when she's 8 to 10 centimeters dilate and transitioning, her pain then is lower in the perineum. Okay, so this is more of a somatic pain. So it's more superficial. So, what medications work for this? Yeah, opioids might help, but we don't want to give opioids this late because we're going to depress the baby as well. Okay, so what can we use for pain management in labor? This is about opioids. Nitrous oxide is a new mode, you might say, new drug that about 5 years ago became pretty prominent. Labor and delivery nurses have to be trained to use it. It's more patient-centered or client-centered. The client tells us when she thinks the contraction is going to be coming, and we have her inhale, and then to stop before, because we can predict how long the contraction is going to last. If it's lasting 90 seconds, then we're going to have her release after a minute. Okay. So, by the way, contractions should not last more than 90 seconds. And a client should not have more than 5 contractions in 10 minutes. Okay, so the nitrous oxide is a good choice. So general anesthesia for labor, for delivery, I should say, is usually only in an emergency. Now, there are other cases that we would do general anesthetic. You probably already know that anybody going to surgery is NPO for at least 8 hours, preferably 12. Okay, depends on what procedure. Okay, so they need to be NPO. General anesthesia, the medication in the gas we use causes vasodilation. So blood pressure tends to drop during surgery and we get cold. Okay, and then when we wake up, we're drowsy. And so any woman that is having a C-section via general anesthesia is not going to have that skin to skin time as soon as those who don't have it. Okay, so she's missing out on that, what we call the golden hour of bonding. We have to really be careful with these cases that general anesthesia, because they could be in their room. They've been through recovery for an hour and then they come back to the room. And if we leave mom in the room with a baby, she might doze off. And her baby, she might roll over on her baby, or baby might be dropped. There's some injuries that can occur. So we have to be very careful with that. The potential nerve block is the most ideal form of analgesia during the transition or late going into the transition phase during labor. Okay, because it's going to anesthetize the perineum and those more somatic areas that mother has most of her pain. Okay, so the pudendal nerve block is much more ideal. The epidural is going to work for labor, early labor, active labor. Once she reaches 4 centimeters, we can do epidural. So here's some information about epidural. I also did a video on the epidural that's in the announcement for week 3. So you can look at that. So epidurals are excellent. They minimize or remove their anesthetics, but they won't paralyze. In other words, a client can still move. She might be a little weak, and it might slow down labor. It might slow down it, but it's still ideal pain management. And it is the most common that we use. Spinal, it is different than epidural. Spinal means that you're paralyzed because it anesthetizes both the sensory and the motor nerves. And it's the spinal anesthesia is the one that's going to give you the headache. Okay. Usually epidurals don't give headaches. So we talked about this before, about the inducibility of the cervix. How successful would it be to just start oxytocin? Well, if we don't use anything to soften and dilate that uterus, if her Bishop score is 4, then labor progress is not gonna, it's gonna be long. Okay, we're not gonna be as successful. So we want a higher Bishop score. And these are just the medications we use for that. We use prostaglandins to soften the cervix and to dilate it. Something really important you need to know. What do you think the answer is?
Hypertension.
Hypertension.
Okay.
You, in a question like this, if you really don't know the answer, a worst case scenario is going to be about hypotension, right? Yeah.
Do we know why?
Yes, we know why. Epidural medications cause pooling of
vasodilate-
blood. Yeah, pooling of the blood, which causes the blood pressure to drop.
Is it A?
Is it A?
Yeah, we need to assess the condition of the fetus. Yeah, we need to definitely know the fetus is doing fine. The rest of them can wait till you get mom all hooked up, check her out. Then you can do history, ask her when she last ate, do her vaginal exam. But I think we need to know right away what the fetus is doing in labor. Okay, so here is a really important slide for you. So you have your client, and we're going to, she's in labor, and she's decided she wanted an epidural injection for pain management. Okay, what is your responsibility as a nurse? Because you have a part in this. You know which clients are scheduled or who have requested. So you want to do baseline vital signs. Before any invasive procedure, you need to get a set of baseline vital signs. You want to make sure she's satisfied with the information that she has about the procedure. So look for the signed informed consent on her chart and make sure and ask her, do you have any more questions about your anesthesia? And then it's usually protocol to give all clients receiving neuraxial anesthesia, like a spinal or an epidural, to give a bolus of IV fluid. Okay, a bolus of IV. I know those streaks that go through the, I don't know what makes that happen. So we usually start out with like a 500 ml bolus of saline. Okay, get that going in because we know the blood pressure is going to drop. Okay, we anticipate the blood pressure dropping, so we have to give her fluids ahead of time. We're going to make sure anesthesia has their supplies because Lord help us if they don't. We want to make sure we help the anesthetist position the patient and keep the patient from moving during the procedure. So what do we do once we have the epidural in? Well, we reposition the patient usually to the left side, lying down. Okay. We want to check the blood pressure. That's the top priority because we do expect it to drop, but we don't want it to drop too low. Why? What are your concerns about a client whose blood pressure drops too low?
Then the placenta
baby.
also drops.
Yeah. So the placenta also will have reduced blood flow, and the baby's heart will begin to drop. Okay. So make sure you check her blood pressure. She might need some more fluid. Check that fetal heart rate. Okay. Look at the epidural site every once in a while. Make sure it's not bleeding. Look at the contraction pattern. Assess your client's pain level. Okay. That's why we do it. So assess your client's pain level. Assess the bladder for distension. We're blocking sensation of pain, but we're also blocking all the parasympathetic nerves. So she's not going to know when her bladder's full. So we have to tell her when her bladder's full. She might have a Foley catheter, not all the time. That might be one of the duties we have to do before we do the procedure, a Foley catheter. And then do a neuro assessment. Can she move her lower extremities? Does she feel, assess her for sensory, see what she can feel in the extremity. So those are your duties. Any questions?
Professor, I have a question for the pudendal nerve block medication. For that medication, would you give that to the patient if it's too late for the epidural medication?
Yes. Yeah,
yeah.
we don't give the anesthesia does the pudendal blocks.
Okay.
Yeah, they inject it directly in towards the ischial spines, towards that pudendal nerve. There's a pudendal nerve, one side and the other. But if we inject one, that's sufficient. Okay, pudendal nerve. It's down where the sacral nerves are. It's part of that branch. It innervates the bladder and such. Yeah. Any other questions? Okay. Well, you can look at this again. Sure, I save that. Okay. So now let's learn a little bit about fetal heart monitor. I did give you a link for learning a little bit more about electronic fetal monitoring. What are we looking at? Now you're not going to see a strip on any exam. Okay, we're not going to put a strip up and you tell us what it is. We're not going to do that. But you need to learn the concepts behind it. So the strips that our machines will spit out have at the top the fetal heart rate. That's the only information you know about that fetal heart, just the rate. We're not doing QRS, PQRS, or ST segments. We're just doing the heart rate. Okay, this is all about rate. If you look at this, let me make it a little bit bigger. By the way, you can see the numbers 30, 60, 90, 120, 150 going up and down. So what would you say the baseline heart rate is for this fetus? Can you see it?
Is it 150?
Yes, it's about 150. And then you notice it drops down a little bit. Those are called decelerations because they're slowing down. The heart rate is slowing down. Okay. Look at the bottom strip. This strip, let's see, it's more than 10 minutes. Okay. So we don't want any more than 5 minutes or 5 contractions in 10 minutes. This client has a lot more than that. So this is too many contractions. It's called uterine tachysystole. Put that in there.
And why does that happen?
Why does it happen? Well, what can you think of a reason that a mother would have too many contractions?
Too much Pitocin?
Yes, too much Pitocin. Let's see. Contractions in 10 minutes. We want 5 or less, 10 minutes. So every 2 to 3 minutes, but not one every minute or every minute and a half. And we want contractions no longer than 90 seconds. Okay. Yeah, if we have oxytocin infusing and our dose is too high, you're going to have uterine tachysystole. And you run the risk of the fetus developing hypoxia because during a contraction, the blood flow to the fetus is reduced, right? We're squeezing it. So it's not uncommon to see a little drop. Okay. And so the uterus doesn't have time to rest between contractions. And, you know, the uterus actually might rupture and she could bleed out. So we have to cut off the oxytocin for a while and then restart it at a lower dose. Oxytocin is very short onset. Duration of onset is very short. Within 10 minutes, you're going to see effect closer to 5 minutes. You're going to see contractions. Okay. So we just shut it off for a minute or two maybe 5. Give the uterus some relaxation time and improve blood flow. And then we're going to restart it at a lower dose. So this is what it looks like. We put external monitors on, and if we can't see it very well, if the tracings are not very good, we're going to do internal monitors. Okay, so we're going to insert a uterine catheter. It's a pressure catheter. We can also instill fluid in around the baby if we have to, and that's called an amniotransfusion if we have to. And then the other is an electrode, just like you put on the chest. We're going to put on the baby's head. Well, you know, the cervix has to be dilated and the membranes have to be ruptured before we can actually attach it to the actual head. Because we have to reach up inside the uterus. Okay, so some normals. Heart rate, normal heart rate for a fetus, the range is between 110 and 160. Okay, accelerations are expected. If baby is moving a lot, then you're going to see the heart rate go up. Deceleration means that there's diminished blood flow. The only time it's okay is early decelerations before a contraction, or as a contraction begins, I should say. As a contraction begins, I'll show you why. So we refer to a heartbeat within the range and good variability as reassuring fetal pattern, reassuring. Non-reassuring would be those that have a lot of decelerations, and you don't need to know grade 1, grade 2, grade 3. So in this strip, mom's having very small contractions, and they don't even look like they're regular. So, but the fetus is tacking at like about 100 beats a minute. And we call this fetal bradycardia because it's below 110, right? It's not much change in the heartbeat. There's no variability here. So that's not a good sign. So you know that if mother has a fever, she's going to be tachycardic. And fetus will probably have a high temperature as well. And the fetus is going to be tachycardic. So this might be a sign of an infection. Fetal tachycardia is above 160. And in this one, mom's having a couple contractions and they look normal. And I'm not seeing the heart rate drop with the contractions. So variability, you know, when you put a pulse ox on someone's finger and you're looking at the monitor, you see a heart rate of 76, 78, 72, 80. It bounces around, right? It's not always the same heartbeat because our blood is liquid, for one thing. Okay. So a fetal heart rate is the same way. It's never exactly the same. We need to see variability. It just means the baby, the fetus, is adjusting to the environment when we see some good variability. So here's some pictures of undetectable variability. The heart rate's the same. It drops down here and here, but it's not changing. There's no variability. That's a bad sign. Okay. Fetal hypoxemia, low oxygen level in the blood, can lead to metabolic acidosis. And then the next one down is minimal variability, only about 5 beats difference in the baseline. We need to see 6 to 25 beats more per minute from the baseline. Okay, we need a moderate amount of variability, like this picture. So the baseline on this one looks like it's about 140, and it bumps way up to 160 at times. So that's 20 beats more. And that's a good variability. And then the one below is just marked. Something's going on with this baby. It's probably a heart problem. And then the sinusoidal pattern is just sinus type rate. It's always the same. This is you'll see this when your baby is hypoxic. In other words, the tissues now, the fetal tissues don't have any oxygen. If there's been a ABO incompatibility or RH incompatibility, and there's hemolysis occurring at that moment or prior to delivery, a severe anemia, things like that. We need to deliver the baby. Okay, a nurse observes on the monitor client is having 6 contractions in a 10-minute time frame. How many contractions are considered acceptable?
5.
5 or less. Okay.
Yeah.
3. Yeah, 3 is better. Oh my goodness. 3 is better. Okay, but we don't want any more than 5. If you had a client that was having contractions, having 6 contractions every 10 minutes, what would you do?
Stop
What's your-
oxytocin for a few minutes and then restart at a lower dose or lower rate.
Yep, stop that oxytocin. So here,
Professor, if
yes.
we get a question like that one in the exam, we should choose 3.
Yeah. You won't get one like this in the exam. You won't get, so actually these, so in that one you would choose 3. Okay. If it was 4, you would choose 4. You need anything below 5 or below is acceptable. Okay. All right. So here's a strip that describes what we call early decelerations. So we've got contractions at the bottom, and we've got the fetal heart rate above, which looks funny, I know. But you notice that the baby's heart rate drops right here, right here, right here, and right here. So where those red arrows are is called a deceleration. The baby's heart rate's dropping below the baseline. But it's it mirrors the contraction time. So when that heart rate drops to its lowest point is the peak of the contraction. This is okay because what's occurring is that the baby's head is being squeezed. Okay, so these are called early deceleration. The head is being squeezed, which stimulates the vagus nerve, which drops the heart rate. Okay, vagus nerve is being stimulated. Okay, and that drops the baby's heart rate, but it comes right back up at the end of the contraction, or even before the end of the contraction. So it's okay, and you will see that. It's reassuring, it's fine. And here's just another picture. You can see where the low point, or we call that the nadir, the low point of the baby's heart rate is still at the peak of the contraction, and they mirror one another. So this is early, and we're not concerned about early contractions. But if we have a baby's heart rate begin to drop at the middle of the contraction, so these aren't mirroring one another, this is happening after the contraction has reached the peak. Okay. And it's late. It's a later contraction. It means during the contraction, the placental blood flow wasn't sufficient for the fetus. For some reason, it wasn't able to keep the baby oxygenated. So late decelerations we're concerned about. There's a compromise between the uterus and the placental perfusion. So what do you think would be the first thing, other than oxytocin, shutting off the oxytocin? What could you do as a nurse? What would be your intervention to help improve blood flow to the placenta?
Lay to the left side.
Okay.
Okay, yeah, turn her over on her left side
Mm,
to get her off of her large vessels. And that sometimes is all you need to do. But turn off your medication. Turn your client over on the left side, give her some oxygen, and you might also give her some fluids and contact the provider. So those are late decelerations. Okay. You can watch this. I think I put it in the list for this week. Okay, so this is another picture of a late deceleration. It's happening after the peak of the contraction, and it's taking longer for the blood flow or the oxygenated blood flow to perfuse the placenta. Okay, it's taking longer. So in other words, that baby is doing without good oxygenated blood for that period of time. Another bad sign is we call variable decelerations. These have nothing to do with the contractions, okay? The reason the baby's heart drops with this is because the cord is being pinched. Okay, the umbilical cord is where the blood travels from the placenta to the baby. So something is pinching it or pressed against it, not allowing blood flow to the fetus. And what we see are very sharp decelerations in the shape of a V. Okay, it just drops and then it's released. Okay, so this is a variable deceleration. So it can occur during the contraction. It can occur between contractions anytime. That's why it's called variable. Okay, so it's a sharp V. Okay, so think of variable as being a V-shaped, which you don't have to know. So we need to do what we can to get release the cord. Other than turning off the medication, what else can we do? What position do you think would be good to put your client in if you saw these variable decelerations?
Trendelenburg.
So Trendelenburg,
Yes.
sometimes a deep Trendelenburg might help. Yeah, or a knee chest position. Okay, so
Kinda
knee
get
chest
that.
like this. What happens if that cord is down low and it's being compressed against the cervix and the uterus or some other soft tissue? When we turn her up on her knees and chest, that drops the baby back down into the uterus and away from the cord. So the knee chest position is most ideal for variable decelerations. Okay. So this is a picture of prolonged. Okay. So the baby's heart rate drops during the contraction and continues and stays dropped well after the contraction finishes. So it's a prolonged deceleration. This is just uterine placental insufficiency, some kind of compromise in blood flow. So we would just do everything we've been doing, stop the medication and turn her on her left side. You can do knee chest position, but that's not necessary.
I'm just asking because this is what I went through when I gave birth. What would be the reasoning for turning you side to side every like 30 seconds? So you go like for your left side, your back, and then your right side.
Is that what they did?
Yeah, and they had my legs pulled up. There was like 6 people.
Okay. What was it during late in your labor?
It started about when I hit 8 centimeters.
Okay, okay. So what it might been the cord also. Okay, so prolonged decelerations with variable decelerations would definitely be cord problem. And that might be why they were turning you different positions, trying to figure out how to get the baby off the cord. So did you ever end up on your knee chest?
When I was pushing, they had like my legs pulled up, and but they
Mhm.
didn't put me like in your picture. They didn't have me
Yeah.
in that position.
Okay, okay. So my guess is that they were just trying to get the baby in a better place, okay? Whatever it took to see improvement in the
Yeah.
fetal heart pattern. The positioning is big. It really is. Okay, so that you don't have to try to understand completely. If you just memorize veal chop, you'll be able to answer a question, okay? So veal and chop, correlating V for variable decelerations with C for cord compression. Okay, so if you see variable deceleration, it's a cord compression, okay, or cord pinching. And then the L is the other bad one, late decelerations. Late decelerations correlates with the P in placenta. So uteroplacenta insufficiency. So veal chop. So the 2 bad patterns that you don't want to see are the variable and the late or the prolonged. Okay. Early decelerations and accelerations in heart rate are fine. Okay. All right. So just memorize veal chop and you'll do okay on the exam. So fetal tachycardia is most common when?
A.
A. Did you say A? That's right. When the mom has a fever, she's going to be tachycardic, and so will the baby. Okay. And this is the same thing, that electronic fetal thing. I separated it out for you in the list of stuff. Let's see here.
Professor,
Yes.
the P and CHOP is uteroplacental.
Yes. Uterine placental insufficiency. So I'm looking at Canvas and looking through the announcements. The pregnant has exam study resources and recordings. So this is exam 1. So here's all the recording. Well, so far what I have, the recordings, and then the recordings from the first 2 study sessions. And then there's one tonight at 8 and one again at 9 that you can go to. And when they're finished, I'll put their recordings here. But also what you have is week 3 is where all these documents I've been sharing with you is today. If you haven't read this, consider yourself behind. Okay. So it tells you how to do your NCLEX. This week we did our quiz and you have NCLEX. Okay. And then the documents that I went through today are right here. This is the video on epidural anesthesia. That's really good. 8 minutes, almost 9 minutes. and then a bunch of other videos that will just help you visualize the concepts. I love videos because some of these are really good. It'll help you with these. And then that other one about the balloon is in here. I should add it, but so that's what we're doing this week. So next week, and please try to attend at least 2 live study sessions this week. Okay.
Professor, I remember the dean when she wrote that introductory, whatever, she was saying that we get extra credit for the study session. Is that what we're going to attend?
You don't get extra credit. Who told you that?
It wasn't the dean announcement, beginning of the semester.
No, she didn't say extra credit for attending the review sessions. No.
Oh, okay.
Okay, I'm sorry. No, there's no extra credit in this class. We don't retake quizzes. We don't retake exams. We don't get any extra credit. Okay. I hate to disappoint you. So try to attend those sessions. Okay. You know, it's students who do much better on the exams. And the short recordings focus on just one concept. So, you know, listen to it while you're driving. Okay. You don't want to watch it, but you can listen to it, or while you're busy doing something else. Okay. And so during class next week on Wednesday, we'll meet like we usually do. You'll come and I'm going to have to look at your photo ID to verify you are who you say you are. Okay. And you're going to need 2 devices, one for Zoom, and then a computer for your exam your Exemplify. Okay. You won't be able to be on Zoom with Exemplify. You'll have to have a second device. If you're testing on campus and you have a proctor, you do not need to be on Zoom. Okay. You're on, but if you do that, you have to come to class when you're done your exam, or you have to come to class by what did I say, 4:15. Okay, you do have to attend class. Even if you go to campus to take your exam, you still have to come to class. Okay, so you're not going to be finished your exam you have an hour and a half. So you're not, you know, so if you come back at 4:15, that would be fine. Okay, or you won't get any credit for attending class. Okay? So attendance is very important. If you're late to this class, 1 after 3, you get dinged 15 minutes. Okay, I'm very strict because I want you here by 3. Okay, so you'll take your exam on Zoom with me. We'll go through the check-in process. No earbuds. Okay. No one else in the room. Quiet. No Apple Watches. No headsets. Okay. We've had students in the past.
Dr. Zeller, I have a quick question. My husband is in Fortis, the same program as well, and he actually has Dr.
Oh.
Roberts at the same time. So he is
Wow.
in the kitchen. I'm right here in the living room, and he's there
Okay.
or in the kitchen.
Yes.
Is that going to matter during our exam? Okay.
No.
Because we get best reception here in this general area.
That'll work. Just keep
Okay.
yourself muted.
Okay.
It'll be fine. But you don't want a lot, you know, if you have children, they don't need to be around when you're taking an exam. You need quiet, you need no one else around so you can focus and not be distracted. Okay. Don't want people coming in and out of the house or in and out of the room where you are. And you don't want to mess that up, because if I remove you from Zoom because you have some distractions going on, that means you failed the test. Okay. You must take the exam on Wednesday next week. Okay. So if someone on campus proctoring you, then it must be on Wednesday. Nicole, you have yours scheduled for Wednesday?
Yes.
Okay, at 9:30 or so in the morning or something like that?
I'm gonna show up before her class. So they're putting me in
Okay.
a separate classroom. It's gonna be, she asked me to show up between 11 or 11:30 for
Okay.
her noon class.
So she's not watching you during the exam?
I'm right next to the dean's office. It's in this private
Okay.
room.
Okay, okay, right. All right. All right. That sounds fine. So if any of you want to do the same thing, you're allowed to do that. You just have to let me know 72 hours in advance. So Friday night at midnight would be great. So I can communicate with whoever's proctoring you. Right? I think we're finished class. Chelsea, if you're talking, you're muted. I'm
Professor
gonna buy
Bell,
a mug.
before you leave.
Yes.
I'm sorry, I just got a question. So is the exam consistent of anything in week 4?
No postpartum on the exam. Just
Okay.
weeks 1 through 3.
Okay.
So antepartum and intrapartum, all the stuff we talked about.
Right.
So if you
Okay.
have not, go ahead, Nisi.
I was just saying thank you. I'm sorry. Keep going.
No. So if you haven't read any of your book, I would do this. I would just get all the documents I've sent you, pull them out, get them ready, go to your book with the documents, and at the top of the document, okay, what is it talking about? Go to your book and find it. Okay, instead of reading page 1 through page 450, whatever it is. Okay,
Okay.
yeah.
Where can we find the previous recorded sessions?
Oh yeah.
They're in, if you let me pull it up, let me show you. I put it in welcome to, no, I didn't put it there. What I did, I went ahead and made a separate announcement. Exam 1 study session recordings. So they'll all be in here. So far I've got 2. Okay. And both of those professors, she's just asking questions and students are answering them. My study session isn't going to be like that. It's going to be more interactive.
I was asking about the class recording.
Gotcha.
Oh, the class recordings. Okay. So let's go back. Let me go to week 2. Welcome to week 2, right here. Okay. Remember I had the pictures for you, and I had this, and I had this case study to watch, and videos, documents, and down at the bottom, it says Zoom class recording. Okay. So every week, that's where I'll put it. Yeah, and those announcements are referred to as welcome to. So you can go to welcome. Although week 1, I don't have welcome to week 1. Okay. So this week, I know I'm finding students really don't access this stuff. I have exam rules here that you can look at. Okay. And then last week's stuff, week 2, when we talked about the antepartum, so that you can watch the recordings. Here, welcome to week 2. So welcome to week, I already showed you that one. Okay. Okay.
So you're gonna post the one on week 3, because I don't see any like link for it on today's
You don't
announcement.
see, well,
Like on
that's
week
because
3. Huh?
week 3, the only thing that's in week 3 right now is what the documents. I'll put the recording from this class now there, so you can watch the recording from class.
Okay.
Is that what you're asking, Nissy?
Yes, that's what I was asking.
Okay. Anybody else have any questions about the announcements? Please utilize the resources that we give you. I mean, I doubt if there's any other college or university do as much as we do for providing resources. I mean, you have access to 7 OB instructors. Okay, their recordings and their documents. If you, who was telling me their husband was, oh, Ashley. Your husband has Dr. Roberts. Of course, he can share those documents with you, but you can share what I have with your husband. You know, the documents we use in this class.
Yeah, I have.
Yeah. So, and I've, the stages of labor and the 5 Ps, those are both from Dr. Roberts' documents that I edited a little bit. Those are from hers. So we use each other's, so there's so much out there. Okay, so I expect all of you to do very well on the exam, especially if you attend review study sessions this week. Tonight, any of you free tonight?
Yes, I could